Good afternoon. Today I'm going to discuss bipolar mania. I'm going to focus more on the mania part because last week we talked about depression. So uh, bipolar mania used to be referred to as manic depression. We have three types of bipolar. Bipolar 1, which is the most severe, bipolar 2, and cyclothymic disorder. Uh, Bipolar 1, like I said, is the most severe type of bipolar, which is kind of described as marked shift in mood. They have a lot of energy, they have high ability to function, and they have highs and low. And they have, it could be combination of both. Mania is a period of persistent mood elevation that they have expansiveness, like they kind of like loud, irritable, extreme goal-directed activity, and they have a lot of energy. Initially, if you meet someone who is going through mania, they are the best type of people you would say you ever met because they are happy. They feel like they are powerful, and they feel so important, and because of that they take unhealthy chances. It could be horrific chances or something that is very hazardous activity. As their mania intensify, they become psychotic, and the hypomania is just a low level and less dramatic mania. Then the cyclothymic disorder is symptoms of hypomania, just like the hypomania, and they alternate with symptoms of mild to moderate depression. What are the risk factors for having bipolar mania? One of them is genetics. Like we said, it runs in family, and anybody who has it has like a 3.9% prevalence that they can have it. Other things, risk factors are neurotransmitters like norepinephrine, dopamine, and serotonin. They are low, they can be in depression, and when they are high, they can have experience mania. And another risk factor is discussed is brain structure or function, like they have dysfunction in their prefrontal cortex, which is the area responsible for executive decision making, and also they have dysfunction in their hippocampus, which is responsible for like memory, decision making, and emotions. So other risk factors with bipolar is neuroendocrine. They say there's a link between hypothyroidism and bipolar, and also with series of having episode of mania, they have increased inflammation in their brain, which impact the structure of the brain. Also, another risk factor is environment. Anyone for children who already have genetic impact, they raised in a bad environment, they have stressful family life, and it can or adverse life events, can start to experience mania. And also in adults, stress can trigger mania or depression. How do we manage bipolar mania? We start with assessment. Some of the things we assess is their mood. Like I said earlier, they have expansive mood, elevated mood, and they could be, feeling of euphoria, like they can do everything. They can, even think they are, equal to God and things like that. Also, we want to assess their behavior. Their behavior is elaborate, and they can have elaborate like scheme to make money, to be famous, to get rich quick, despite objections from family and friends. And they said also their behavior, they can give away money, It can give away price, possession, and things like that. In their thought content, we assess their speech patterns and the content. We notice that the speech pattern is described as being pressured, meaning fast, very fast. They talk very fast, like you can hardly get in a word. And another type of thought processes they have is circumstantial, the way they speak. Like they can add unnecessary details, or tangential, like they lose the point of, the point that they are trying to make. And also they behave grandiose, like highly inflated of themselves. Also, we assess their cognitive functioning, which initially they have high functioning level that they can take care of, that they can do this, they can achieve so much, they have goal-directed behaviors, but as the problem, their mania deepens, then they start to lose, lose touch with reality, and they have poor judgment. Our primary consideration in taking care of someone with mania is, to prevent exhaustion, because during this time that they are in mania, they have poor judgment, and they have excessive and constant motor activity, like they are moving around. A lot of them might even be driving for days. They were not going to go to sleep. They are not able to sleep, and also because they have difficulty in evaluating reality. Like, this is not right. They feel that they are achieving a lot of things. They are doing so much, but if you go behind them, they are making a lot of mistakes. In acute phase like this, they might need to be admitted. And in continuation, when they are admitted, we want to make, when we're communicating with them, we want to make it simple, use calm and firm approach, and also be consistent, supervise them in what they are doing. Safety, is also very important, because they are very impulsive, meaning that they can do things without thinking through. So we want to make sure they are in a safe environment, the milieu is safe. We have low stimuli in the environment, nothing that is going to make them to be, extensively stimulated. Encourage rest periods. Like, we want to redirect the aggressive behavior. Like, if they are doing something that is not appropriate, like walking or running down the hallway or pushing someone, we need to redirect that behavior, and have them know that that is not appropriate, and they can take a time out, to go rest in their room and things like that. We will also monitor their intake and output, also their physiological state, like vital signs. Like I said, supervise their meals. We want to make sure they sleep at night, because people who have mania, some of them will not sleep at night. They might tell you they are doctors, they are making rounds on their patients. We have to redirect them and explain to them, family, this is bedtime. They need to go to bed. If they need medication to help them rest, yeah, we can give appropriate medication when it's indicated. We can suggest also, like, taking a warm bath and things like that. With their hygiene, we want to encourage appropriate clothing choices, because we found out that some women, when they are mania, they might dress inappropriate, they might dress in a sexually manner and things like that. And then in other interventions or management, medications. We can give them medications to reduce agitation, like benzodiazepine, example, Ativan, or antipsychotics like olanzapine, Zyprexa. They can, offer them to help them kind of relax or reduce their agitation. Other medication, major one that for mania is mood stabilization medications. Like first one is lithium, and also anticonvulsant like Depakote, Tegatrol, Lamictal. all these medications, they have side effects, which we have to explain to our patients what those are, like the mood stabilization, lithium. Lithium, we need to teach the patient and family about lithium. That number one, the lithium is not addictive, is to prevent relapse, and they need to have their lab drums. Number one, drawn until they reach therapeutic level. Then after that, once they reach their therapeutic level, we need to explain that they have to have like recurrent lab draws. So anybody who's going to be taking lithium has to understand that they have to have their lab drums at various intervals to measure, make sure they are at therapeutic level. And also we need to teach them about lithium toxicity, that's things that can lead to lithium toxicity. Like we want to make sure that they are taking, because sodium can affect the levels of the lithium in their bloodstream. So we don't, if they take too much sodium, it can lower their lithium level. If they take low sodium, it can make their lithium level go up. So in essence, we want them to take constant level of sodium that they normally take, and also we want them to have enough fluid intake between 1500 and 3000 ml of fluid every day. Also, they need to stop taking lithium if they are having excessive diarrhea, they are vomiting, or excessive sweating, because when they are dehydrated, they can have lithium toxicity. They need also to inform their doctors, their primary doctors, if they are taking any other medications that might interfere with the drugs that they are taking. If there is a need for lithium to be discontinued, we have to explain to them that usually they have to taper it off, like take it down slowly until they can withdraw it. So we want to also explain to them about, other medications, like I mentioned, all these medications have side effects. Even Depakote, they need to have maybe lab draws for their liver functions, and also lamotrigine, Lamictal, can produce itching. So we need to kind of explain that to them. Also, we want to teach our patient and the family that they shouldn't just take their medication for any reason. If they have any untoward side effects, they need to call their doctor, and the doctor will try to see if we can switch them to other medications. Also, other things that they can do in terms of management for mania also is to have therapy, psychotherapy with the patient and also the family. And that's the end of my topic today. If you have any questions or any comment, please post them. Thank you. Next week I'm going to talk about schizophrenia. Thank you.